welcome Professor Vincent Gregoire.
Thank you very much for your nice introduction. If I knew you would read it, I would have made only 2 sentences.
I wouldn't want to skip anything.
Thank you anyhow. So, I've been asked to rediscuss with you the issue of contouring structures in the field of head and neck, so mainly target volumes, but I will also show some data. Do you hear me in the back? Yes, because I don't like to have a microphone, I don't need prosthesis yet. But I will also discuss at the end of my lecture about organ at risk, because now we have also an atlas, as you know, that has been recently published in the field. But before we go to delineation, I think we need to agree on the selection aspect. So I put it contouring in my title, which means selection and delineation. And so what I will be discussing with you today is mainly the issue of GTV, CTV, and a little bit of organ at risk in the field of head and neck. I'm used to show this data, or these 2 pictures, just to set the scene. And I'm afraid to say that still the scene has to be set up, and still the issue is not fully resolved. This is an exercise which I was asked to participate in 2004. I was sent a set of pictures with a GTV of the oropharynx, white tonsil, invading a little bit the soft palate and the glossotonsillar sulcus. It was less than 4 cm, but more than 2 cm in largest dimension, and it was a small lymph node, more than 1 cm, so it was a T2N1. And a bunch of experts, and I was one of them, was blindly, of course, we were asked to do a full delineation. And in fact, this was what we received, and this is what we produced. And the message, or my message, is that 19 experts in the world, and they were coming from Europe, North America, Australia, and Asia. We, all of us, we did delineate something different. And obviously, you may say, oh, there was a small difference between this person and that one. Indeed, very small difference. But obviously, very small difference between these 2. Okay. But look at this one and compare to that one. There is obviously a big issue, a big difference. It's an issue. And I guess, I don't know, because it's fully blind. I know I am one of them. Probably, and I'm not this one, I can tell you. Neither that one. So probably what they did is to transpose on a 3D basis what they were used to do on a 2D basis. So obviously, this is just the first picture to tell you there is an issue. And in my opinion, we are now dealing with wonderful equipment. It can be Linac-based or Tomo-based. But at the beginning, we need to agree on what we select and what we delineate. Because obviously, if you do planning with these CTVs or with this CTV, you will obviously end with a different dose distribution. But are you sure that you don't overtreat this gentleman, or that you don't undertreat that particular gentleman? So that's the issue. So the first issue is, can we agree on what we want to delineate? So it's a selection issue. I want to do that, I don't want to do that. First question. Second question, now that I know what I want to do, how do I do it? What are the guidelines for me to do the delineation of the CTVs and to do the delineation of the organ at risk? And then the third will be, okay, there are uncertainties, I put PTVs, I put PRVs, and the fourth issue will be, with the help of the medical physicists, dose volume constraints that we propose, can we indeed have a good dose volume distribution, dose distribution that we can accept. So I will be talking in the lymph nodes area of the neck with the TNM atlas, with the various nomenclature that you are used to, and you know the surgeons were used to divide the neck into various levels. I will be using this classification plus the updated one that we proposed 2 or 3 years ago. And in a nutshell, really this, in my opinion, the summary of the message I will deliver to you is that we know, this is just to tell you that we use the anatomy of the lymphatic system, the lymph node distribution from the clinical data, the radiological data, pathological data, and then we could also have a look on the pattern of failure. And all together, when you put all this data, you can come up with some guidelines for the selection of the target volume, and this is really a summary. If you take an untreated patient, you know that the pattern of lymph node infiltration will depend on the location and to a lower extent on the T stage of the primary. So you have something which is predictive or predictable, which means you will not treat from base of skull down to clavicle every single patient. And second, because of that, you could then go for selective treatment. And I say treatment. Treatment can be a neck node dissection, can be a neck node irradiation. Because obviously, there is no reason why we as radiation oncologists should do differently than they as surgeons. Because we have a similar goal, which is to cure the disease above the clavicle. And so it's really the same goal, it's the same philosophy of what we should treat with 2 different knives. A surgical knife or anatomic knife, if you allow me to say so. So I guess you know it. You know you take an oropharyngeal tumors. These are all data, clinical data, the fingers, of 2 gentlemen, one from Houston, one from France, Paris. And it shows that if you take all together oropharyngeal, you have a pattern of lymph nodes infiltration. Level 2 almost always invaded, and then goes down to level 3 and 4, level 5, level 1. So not all lymph node areas have the similar risk. This is ipsilateral, contralateral, smaller incidence, as you know. But again, not all levels do bear the similar risk. So it means if there is a different risk, maybe we can use this in the equation when we do the selection and then the delineation of the target volume. For nasopharyngeal, for retropharyngeal lymph nodes, retropharyngeal lymph nodes, as you know, we need CT or MR, typically. And there are few series that look at the probability of infiltration of the retropharyngeal lymph nodes as a function of the location of the primary and as a function of the positivity of the neck from level 1 to 5. So if you have a node negative neck based on imaging, the probability of having more than 5 millimeter retropharyngeal lymph nodes is mainly observed for posterior pharyngeal wall, of course, because we know that the posterior pharyngeal wall will primarily drain into the retropharyngeal lymph nodes, isn't it? You know it. And of course, and I guess you are experts in nasopharyngeal, because nasopharyngeal carcinoma will primarily drain into the retropharyngeal lymph nodes. That's for the node negative neck. If you take the node positive neck, then you see that there is clearly a much higher risk of retropharyngeal lymph nodes infiltration. And you know that if you take laryngeal, there is very low infiltration of the retropharyngeal lymph nodes. And indeed, Rouvière mentioned it already 80 years ago, 1939, his first textbook of anatomy. The larynx does not drain into the retropharyngeal lymph node. So again, we will be able to do differently regarding the retropharyngeal lymph nodes, whether we speak of a node-negative neck or a node-positive neck, whether we speak of a posterior pharyngeal wall or a laryngeal squamous cell carcinoma. Then we can go to pathology. And this group of surgeons from the Memorial Sloan Kettering Cancer Center in the 80s, so all data, I agree, extremely good data, late 1970s, 1980s. They did systematically a radical neck node dissection. Radical neck node dissection means you remove level 1, A and B, 2, 3, 4, and 5. You remove the sternocleidomastoid muscle, and you removed the jugular vein. Then they looked at the different levels, and they asked the pathologists, could you please look at the infiltration incidence? And as you see, if you have the node-negative neck, node-negative at that time means palpation, no CT, no MR, and of course no PET. Then you see oropharyngeal primary. You see that where you identified positive lymph nodes, these lymph nodes were in level 2, 3, and 4, not in level 1B, not in level 5. Interesting. But if you have a node positive neck, then all lymph nodes are at risk, at least above 5%. And some are clearly above 10%. And some are clearly close to 100% infiltration. This again is telling us we may want to treat differently a node negative compared to a node positive in terms of selection of the target volume. Then the question is, should we always treat both sides of the neck? Are there some primary locations where the risk of contralateral is really low? There are few data. You have the anatomy, plenty of data. I'll come back to that in a minute. But you have a prospective series coming from PMH in Toronto. They look at small, typically T2s or very small T3s and few T1 of the tonsil. Mainly node negative. And they decided a long time ago to only go for unilateral treatment. At that time, no iMRT. Wedge spare. Still, low dose to the contralateral neck. Probably below 10% of the prescribed dose. And they observed the recurrence on the contralateral neck, which occurred in 8 patients, which means 3.5%, quite acceptable. But who are these 8 patients, or who were these 8 patients? Patients with soft palate infiltration, patients with glossotonsillar sulcus infiltration. So it means we do, as clinicians, we do have data to identify those patients who may not systematically require a bilateral neck node irradiation, which is quite interesting, because then, for physicists, it will be a piece of cake to give less than 5 gray mean dose to the contralateral parotids, or even less than 4 grays, if they are very good. And then, do we have data on the pathology for the contralateral neck or the ipsilateral neck? Very few data. Incidence will be different, but the selection will be the same. So this is oropharynx, no, this is oral cavity, mainly oral cavity tumor. So level 1B, 2 and 3 are at risk. If you go to the contralateral side, it's mainly the same distribution of areas at risk. Last piece of data, Do we have data coming from the iMRT era? iMRT era means that you need to define your targets, which we were not used to do in the past with 2D. And then we could look at the recurrence within the target volumes, in-field recurrence, and the recurrence outside of the target volume, what we would like to call maybe geographical miss or misjudgment or whatever you call it. And this is a selection, I agree with you, and I agree with you, it's not updated, but the point is still valid. When they look at the neck failure, in fact, they found more failures within the PTV, within the defined target volume, compared to failure in the untreated levels. Indirectly, I agree with you. It documents, it shows that if you properly, selectively decide to irradiate or not to irradiate some neck structures, yes, you could do it, because this is obviously failures, which is quoted, unquoted, within an acceptable range of failure, and the majority of the failures, they do occur where you give the high dose level, because probably of intrinsic radiation resistance. It's a matter of biology, providing the dose was properly delivered. So when you put all these data together, and we did it, it was published, as you know, when you put all these data together, you can come with proposals, with guidelines, that indeed propose selective selection of the areas to be treated in the neck, depending on the location of the primary and depending on the stage of the neck. And I will not go through it because of the lack of time, but this is oral cavity. This is a staging, AGCC 1997. This is the ipsilateral neck, and this is the contralateral neck. And you will show further tables with the other primaries in a moment. I see that some of you are taking pictures, which is wonderful. Everything has been published. And if you wish, I wouldn't mind giving you a PDF copy of my presentation if it can be of interest to you. So node negative and node N1, a single lymph node. In level 1, 2, or 3, you can be selective. And if you have an oral cavity, typically you treat level 1, 2, and 3. 1A, 1B, 2, and 3. And there are some data suggesting that for anterior tongue tumor, you may have also to treat level 4 because there is a direct drainage via the anterior compartment into the level 4 of the neck. When you have multiple lymph nodes, we have no data to suggest that we could be selective. And obviously, surgeons will do a comprehensive neck node dissection, level 1 to 5. We will do a comprehensive neck node irradiation, level 1 to 5. When it's an N3 big node, then it depends. You obviously are not selective, and you may even want to extend your target volume, because you may have to include some normal structures, I don't know, the parotid gland, or the paraspinal muscles, or the sternocleidomastoid muscles, or even the skin, depending on the N3. N2C, you know what is N2C? It can be a single lymph node on the contralateral side, is N2C. It can be both lymph nodes in one area on both sides. It can be multiple lymph nodes on both sides. So what we proposed is that we select based on the classification on both sides of the neck separately. So it can be selective on both sides, it can be non-selective in one side and selective in the other side. And then we go on with oropharyngeal, typically 2, 3, and 4. Don't forget the retropharyngeal, even for a node negative or N1 neck, if it's a posterior pharyngeal wall tumor. And 2 and 2B, I believe we cannot be selective. And the same for N2C, and N3. Hypopharynx, as you know, are extremely lymphophilic. Bett disease, as you know. And so we propose to only be selective in the node-negative neck, and even not in N1 disease. In N1, N2B, N2C, we propose not to be selective at all. Don't forget that if you have an esophageal extension of your hypopharyngeal tumor, or you have the apex of the periform sinus, then, based on anatomy, these two structures will drain in level 6. And then you may have to include level 6. Don't forget that if you have a posterior wall of the hypopharynx, it goes into the retropharyngeal lymph nodes. And then same for the other lymph nodes. Laryngeal carcinoma, very seldomly invasion of level 1B. So you can be selective, of course, for N nodes N1. If you have a transglottic extension or subglottic extension, then level 6 become at risk. N2 and 2B, you can skip level 1B. Level 6, if you have transglottic or subglottic extension, the rest is as usual. NPC, you should tell me what to do because you have much more experience. Basically, you cannot be selective. I know that there is an issue, I don't know if it's a big issue, whether you should or should not include level 1B. As you can see, I did not put level 1B. I understood that Anli in Hong Kong is not treating level 1B for the node negative, but she's treating level 1B for all the other situations. I don't know what you do. You will tell me during the discussion, but obviously you need to include every locations, including the retropharyngeal lymph nodes, as you all know. Now, can we sometimes be unilateral? The answer is yes. Oral cavity, lower gum, lateral border of mobile tongue, lateral floor of mouth, retromolar triangle, the cheek, these structures will not invade on the contralateral side. And even if you have a node positive on one side, in my opinion, you can clearly spare the other side, which will make the life of your patients much easier, as you all know. We discussed the tonsil fossae and the tonsil of penis. Small one, T1, T2, not invading the soft palate, not invading the glossotonsillar sulcus and the base of tongue. You can be unilateral. Few cases a year in my practice. And then I've seen 1 or 2 patients. The lateral wall of the piriform sinus, if you go to the textbook of Rouvière, anatomic textbook, it will be mentioned that the lateral wall of the piriform sinus does not have lymphatic drainage on the contralateral side. I've seen maybe 1 or 2 of these tumors, which is quite rare. And all of this has been published, as you know, and you can download these articles and I can give you the PDF, as I mentioned to you. So, first, we have to agree on the selection. And then, the question is, how do I delineate these areas in the neck? So, it's a delineation issue. And you may be aware of the latest update of the guidelines that we published in 2013. It was, as you can see, a consensus among all groups, including Asian groups. This is Hong Kong group, the Australian, the North American, the Europeans. All groups together, we agree on the delineation. So we propose an atlas for target volume delineation, which hopefully will be used worldwide. Basically, it's a revision of what we had published in 2012. What we have done is that we also included additional lymph nodes. For example, we went into the occipital lymph nodes, the retroauricular lymph nodes, the parotid lymph nodes, the buccofacial lymph nodes, and then we revised the delineation of the various structures, and we hopefully made it a little bit less confusing to all of us as clinicians. So we delineate all the boundaries in text, and there was an atlas which is downloadable as a PDF file, and you can easily have it. So this is the 13 or 12, no 13 different areas that we did delineate. So we expanded, as I mentioned to you, because we will also discuss about the occipital lymph nodes, the parotid lymph nodes, the retrostyloid lymph nodes. All of these lymph nodes will be delineated and defined in this atlas. We use some help. For example, for the upper level of level 2 in a node-negative patients, when a surgeon performs a neck node dissection, do they go up to the base of skull? No, they do not. This is clips that were put at the upper level, the cranial level of a typical neck node dissection. So obviously, this is the parotid gland projection, by the way. So if you can limit your CTV up to there, you will be able intrinsically to spare part of your parotid glands more easily. Also, we ask surgeons to put clip in the lower aspect of level 4, because typically it was mentioned, oh, when you do a dissection of the lower neck, you go down to the clavicle. Okay, I'm not sure. And indeed, when for node negative, they don't go down to the clavicle. They stay they make a distinction between what we will call the medial supraclavicular lymph node. You will see that in a moment. And the most difficult, or the most difficult or easy, was what was the posterior level of level 5. Level 5 are the lymph nodes wrapped around the spinal accessory nerve. The spinal accessory nerve is a nerve that by definition, not by definition, but that it's a nerve that you cannot see. On a CT, forget about it. On an MR, even forget about it. It's somewhere around there in the fat. And typically when you discuss with anatomists and with surgeons, they will tell you it's more anterior than posterior. So we propose a line that join the anterolateral border of the trapezius muscle. And this is where you have the level 5 lymph nodes. This is upper limit of level 2, I mentioned it to you. What is the upper limit of level 5? The upper limit of level 5 is, from a surgical point of view, when the spinal accessory nerve enter into the sternocleidomastoid muscle. As we don't see the spinal accessory nerve, then I ask you to say that's typically at the level of the iris bone. So the upper limit, the cranial limit of level 5 will be at the iris bone. Above, this will be called the occipital, and then later on the retroauricular lymph nodes. You will see sections. So when you put all of this together, this is a view where you have the typical level 2, level 3, level 4, which is level 4A, and then below, down to the clavicles, also called the level 4B, also called the medial supraclavicular lymph nodes. The one that I typically delineate when I have a level 4 or maybe a lower level 3 infiltration. Then you have the typical level 5. Above cranial, you have the occipital lymph nodes. These are the ones I do delineate seldomly for scalp tumor, typically skin tumor on the scalp. Then when you go further down, you have the lateral supraclavicular lymph nodes. I guess you are used to delineate this because it's mainly invaded for NPC. The anterior compartment, prelaryngeal, pretracheal, recurrent lymph nodes. Level 1B, submandibular lymph nodes. Level 1A, submental lymph nodes. You have the the retropharyngeal and the retrostyloid, we'll see it. You have the retroauricular lymph nodes, typically for auditory canal, or, yeah. And this is the parotid lymph nodes, which I have to admit, we don't irradiate primarily, but surgeons may do a parotidectomy because of a skin cancer, pre-auricular skin. The first echelon will be in the parotid lymph nodes, as you know. Okay, let's have a look from caudal cut up to cranial cuts. So here we are at the bottom of the neck. And so you see here the level 6. Level 6, from an anatomic point of view, there is a more anterior compartment which is between, called the pre-laryngeal or the pre-tracheal, you know, between 1 and 2 sternocleidomastoid muscle, you have a space. That's where you have your level 6, pre-laryngeal, pre-tracheal lymph nodes. And this is the peritracheal and recurrent lymph nodes area, level 6B. So typically thyroid cancer, subglottic extension, esophageal extension of an upper pharyngeal, that's where I delineate level 6. It's not often, I have to admit. This is the really lower part of the jugular carotid lymph nodes, so-called level 4B in English, the medial supraclavicular lymph nodes. You have the sternocleidomastoid muscle, you have the scalenus muscles, and in between you have the fat, which is level 4B. We'll move slightly cranial. You are above 2 cm from the joint between the clavicle and the sternum. You have the level 4A. 6 and 6B, and then lateral. So it's a former triangle of Ho, HO, defined from the Hong Kongese radiation oncologist, which is typically delineated in node-positive nasopharyngeal carcinoma. I guess you are much more expert in this area than I am. We are in the middle neck, easy for level 3. The easiest level to delineate, because you have the sternocleidomastoid muscle, anterior part, posterior part, you have the scalenus muscle, and then this fatty space, jugular vein, the carotid artery, you exclude the thyroid gland, this is level 3, easy, easy. Posterior is level 5. Trapezius muscle, sternocleidomastoid muscle, level 5. Anterior, seldomly delineated, I have to admit. You have the level 6A, which is the pre-laryngeal lymph nodes. We move up, we move cranial, a small tiny space between the anterior belly of the digastric muscle is level 1A. 1, 2, 3 cuts, no more. When I say cuts, I mean 2 millimeter thick cuts. By the way, you have seen that this is a planning CT with contrast, and I know that you use IV contrast for all your planning CT. This is, in my opinion, not a must. Yeah, it's not a plus, it's a must. I'm sorry. Because I would be indeed in real difficulty to delineate these levels without contrast, especially at this area of the upper neck, where you have so many structures that I cannot find my way out. Level 2, quite easy, upper jugular node, sternocleidomastoid muscle, submandibular gland, this is level 2. Posterior, the tip of level 5, and when do you stop level 5? At the level of the iris bone, as I already mentioned to you. And then anterior to level 2, level 1B, including the glands, because the submandibular gland is part of level 1B. We moved up. We are at the uppercut to level 1B. Level 1B stop. You have still a little bit of submandibular gland, And when you have the end of the submandibular gland, you see the muscle over there, which is the pterygoid muscle. That's typically the cranial limit of level 1B. Lateral process of C1 is the upper limit of level 2. Lateral process of level 2. Posterior to level 2, at this level, it's not the level 5 any longer, but it's the occipital lymph nodes. You have the parotid lymph nodes. You have here the retropharyngeal lymph node. Now you know retropharyngeal lymph nodes, you have the lateral group and the medial group. The medial group is extremely seldomly invaded. There are data comparison between comparison with anatomy on CT or MR. And so, distinction with the previous version, we propose to only include the lateral retropharyngeal. In other words, by not including the medial, you can spare part of your constrictor muscle. And then this new area that we delineated, which is that area, it's anterior to the masseter muscle. You have the vein and the artery, which are the buccofacial vein and the buccofacial artery. This is a small area, which is the buccofacial lymph nodes. And the buccofacial lymph nodes is the one you may want to include for skin cancer or for maxillary cancer, transfixing and invading the skin of the cheek. And then we are moving up again, the buccofacial lymph nodes. You have the retropharyngeal, 7A, and then the prolongation, the extension, the cranial extension of level 2 is the retrostyloid lymph nodes. The retrostyloid goes up to the base of skull. So it's the prolongation of level 2. When do I irradiate the retrostyloid lymph nodes? When I do have an infiltration in the upper level 2, then maybe you may have retrograde lymph flow, which means that you may then increase the probability of having lymphatic infiltration higher up in the neck. This is what we call the retrostyloid lymph nodes. This is the occipital, the retroauricular from the tip of the mastoid. This is the parotid lymph nodes. And you know, the parotid, you have the superficial, the intraparotid, and the parotid lymph nodes. As I mentioned to you, this is typically not something you do delineate because it's after a total parotidectomy for skin cancer or preauricular skin cancer, for example. All of this can be downloaded. So if you go to the website of Elsevier, you can have supplementary data, and it's a PDF file, 2 or 3 megabytes file. It's 2 mm cut from the clavicle up to the base of skull. You can easily download it and put it somewhere in your computer. Few also extension in these guidelines. What do we do when we have positive lymph nodes? So all what I mentioned to you was for the node negative. But when you have a node and you see you have 2 lymph nodes, 2 GTVs, what do? You do what I just mentioned to you, but you may want to include some additional structures. For example, if you have lymph nodes really abutting the sternocleidomastoid muscle, and depending on the size of the lymph nodes, there are data suggesting that the larger the lymph nodes, the higher the probability of extracapsular infiltration. And when there is no fat play between the nodes and the muscle, there is a probability of intramuscular infiltration. And so we propose to at least prophylactically, up to a prophylactic dose, and we are not going to define what is a prophylactic dose, 50, 60, 66, that's another debate, and we may disagree. But this is the, in red, the prophylactic target volume, and in blue, the so-called therapeutic target volume where you will give the highest dose. Typically, this would receive, in my practice, 70 Gray, and the wet area would receive 50 Gray or 2 Gray equivalent if you use a different dose fraction. If you're node positive, or if it's a post-op situation, you can apply the same principle. But you will have to take into account that you need to be sure that you covered the full oncologic treatment. I mean to say, and this was also published somewhere in 2006. So in a post-op situation, be sure that you cover areas that may not have been covered by the surgeon. Let's assume that for whatever reason, a surgeon decides to do an operation for T2 and 2B tonsil foci, which in my practice would typically treat with concomitant chemoradiation. But let's assume they do it. They will not dissect the retropharyngeal lymph nodes, but you need to cover the retropharyngeal lymph nodes. T2 and 2B oropharyngeal, high risk of retropharyngeal lymph nodes. Or if you have a lower neck infiltration, be sure that the surgeons covered the medial supraclavicular lymph node. They may not have done it. You may have to include this in your target volume as post-op situation. Also, this was for the post-op situation, and this was in the node positive neck. These are things that also you have a big nodes in level 2, a single lymph node in level 2, typically oropharyngeal. You will say, okay, I go 2, 3, and 4. But these lymph nodes, 2.5 cm, is really close to the submandibular gland. You may want to extend into level 1B because you may fear to have an extracapsular extension and invasion in the in the submandibular gland. This is typically what is mentioned in the publication. This is just to show you that in 2007, the Dutch, they did a second exercise to really see whether or not the use of guidelines could help homogenizing the treatment. And I have to say that, yes, it does for level 3. That's absolutely consistent. It almost does it for level 2. I don't know why some chap did include the parotid glands. Maybe they wanted to include the parotid lymph nodes, which in my opinion was not really what they should have done. But it's the message, yes, by using guidelines, we will decrease the heterogeneity, we will increase the homogeneity between us. And I think it's what we should do. It's why we are here on this rainy Saturday morning. One slide. I'm almost at the end of my lecture. What do you do for the GTV and for the CTV from the primary tumor? GTV, typically I define it on CT. But when it's close to the base of skull, I do a fusion or registration, with MR. Obviously, it helps NPC. Ethmoid sinus, I do use an MR fused or registered on with my planning CT. I don't use it for the low oropharyngeal base of tongue. I use my diagnostic MR on one screen and my planning CT on the other screen. If you can fuse, that's fine. But the error on the fusion when you are not close to the base of skull is quite high. So what you think you will gain, you may lose it because of the uncertainty in the registration. The question is how you delineate your CTV. And then typically what I do is that I never use margin, or at least I never use automatic margin. Yes, when I have a base of tongue, such as the case we discussed, in the base of tongue, cells can easily infiltrate in the muscles or between the muscles. I typically use a 1.5 cm margin for the prophylactic dose CTV and then a half cm margin for the therapeutic CTV. That's indeed a kind of geometric infiltration because there is no anatomy. But when I am in the tonsil foci, if it's a T1, I know that the risk of retropharyngeal lymph node, or of parapharyngeal space for T1, the risk of infiltration of the constrictor muscle is minimal. I don't include the parapharyngeal space. With the T2, T3 of course, and of course T4, because it means parapharyngeal infiltration. I do include the parapharyngeal space. Supraglottic tumor. I always include the pre-epiglottic space up to a prophylactic dose, because we know that cells could easily cross the cartilage and invade the pre-epiglottic space. When I have a nasopharyngeal, I include the parapharyngeal space from up to down, because obviously that's the first route of infiltration. So what I tend to do is really to appreciate, based on the location of the primary, what are the spaces which are at risk for infiltration. I have a posterior pharyngeal wall tumor. Without infiltration of the longus capiti muscle, I include up to a prophylactic dose the longus capiti muscle, because you never know, the fascia may be slightly eroded, you cannot see it on the MR. But then I will exclude them for the therapeutic dose. That's, for example, a few examples. Could FDG help you in this setting to define your GTV? It was used by some of you. And indeed, I and others, we have shown that compared to the macroscopic tumor specimen, FDG is better than CT or MR to define your primary, providing you use proper software for the delineation of your FDG avid area. And the visualization by a nuclear medicine expert, with all due respect, may not be the best. So when we use FDG PET to delineate our GTV, we use an automatic segmentation algorithm which is based on gradient recognition. If you are interested, ask me, I'll give you the reference that we are using to do it. This is, why do I put this data? I don't remember. This is to show things are moving during treatment, pre-treatment, week 3 of concomitant chemoradiation. So obviously, we may need to do adaptation of the treatment depending on the case of the primary. We may want to do adaptation because, as you can see, with a small shrinkage of your primary target volume, the parotid is moving, and we include more parotid glands after fraction 25 compared to the planned CT. And when you do adaptation, you may have to fuse the volume and the dose to be able to get the composite dose distribution. So, last part, 5 minutes or maybe 7 minutes. What about OAR delineation? As you may know, this is a mistake. It's sorry, 2015. So a few months ago, one or last month or the one before, Charlotte Brouwers from Groningen published the consensus atlas with OAR delineation. As you can see, you recognize the same names that for the CTV consensus. And obviously, she did review all the various organ at risk, from the base of skull, or even from the brain, down to the level of the clavicles. She also proposed very good boundaries or guidelines to delineate or to define the boundaries of the various organ at risk. And I can only advise you also to follow it, to try to be systematic and consistent when you do your target volume delineation. For example, these are the constrictor muscles. These are the cheek mucosa, the parotid glands, the lip, the oral tongue, and so on. I have few cuts. This is the thyroid glands. This is the carotid space. This is the most difficult for me, extremely difficult, which is the brachial plexus, extremely difficult to see. And then you go up, you have the esophagus, thyroid glands, the carotid, I guess. Then you are at the level of the larynx, the constrictor muscle, very nicely described, the submandibular glands. Here you have the pharynx, for example. I guess this is again the pharynx gland. Then you go up to the base of skull with the cochlea, which has been defined. This is the optic tract with the optic nerve, with the chiasm. And this is, I guess, the carotid arteries, I guess so, the optic nerve and the chiasm. And this is a table with anatomic definition of all the boundaries for the various organoids. So it's 2015 published. I also have it as a PDF in case you want, and there is also an atlas which is associated to this, so you can download the PDF file so you can use it on a routine basis. And this is a consensus with a pretty good consensus between observers for at least the oral tongue, the powerful gland. Still some deviation, but at least it will also, I guess, homogenize the practice among radiation oncologists. So my last slide. What I tried to do, and I'm sorry if I was too long, although I think I kept my time, why do we need guidelines? Why do we need guidelines? What is the purpose of the guidelines? This is a painting of the sea, which is viewed through the window. Why do I use this picture, which by the way was called The Human Condition by the painter René Magritte? The reality is huge. The sea, by definition, you see the sea, but you don't see the end of the sea. It's huge. So when you have to describe the sea, number one, you have to view it. And when you view something, you view it through a window, which is restricted. You view it through your eye. And because we are simple human beings, we are restricted by definition. Then when you explain to somebody what you have seen through a restricted area, you end up with a small painting because you forgot something, because you are not brainy enough. And so you're trying to restrict and simplify things. The message is that we, as simple human beings, we try to simplify all what we do, all what we describe. That's human nature. It's human condition. So then, my proposal in this environment is to follow guidelines. Let's apply it. Let's learn. Let's make mistakes from the guidelines. But then, from 5 years later or 10 years later down the road, we'll revise the guideline because we will have learned something from the success and the failures. So that's why guidelines are meant for, and I hope that it will be useful to all the medical, to the radiation oncology community all over the world. And I would like again to thank you very much for your kind invitation.